Dr. Pavessio's assignment for this meeting was to address the matter of cortisone therapy, corticosteroid therapy, prednisone therapy for the care of patients with birdshot retinochoroidopathy. In his introduction, of course, he makes some of the points here that the preceding speakers have already made, and he also goes on to emphasize that if one identifies the problem early enough and steps in with therapy early enough, the symptoms and the signs of the inflammatory disease can be reversed. There comes a point when pathology that is irreversible, however, does develop. So making the diagnosis early is critical. Having the patients referred for proper care early is critical. That's one of our biggest challenges, is that the retina doctors sometimes, who are the first to see these patients, hang on to them for inordinate amounts of time before referral. You're going to hear later about from Hank Kemplin about some of the best ways that we know of today, and also from Dr. Herbort, for assessing patients so that one can make the diagnosis earlier and so that one can follow them in terms of disease activity better. So Carlos makes the point that obviously the objective of treatment should be rapid and maximum control of inflammation. Inflammation is bad. It produces damage, and the quickest way to suppress that is with corticosteroids. First used in a human being in 1949 at the Mayo Clinic, nothing since has been discovered that will suppress inflammation as quickly as corticosteroids. They come at an extremely high price, and I'll come back to that later. I'm also going to make some comments about the failure of corticosteroid therapy in saving vision in patients with birdshot during my talk. So Carlos makes the point that systemic steroid is likely to produce improvement in the early stages, but not at acceptable levels. So while his assignment was to talk about steroid therapy for patients with birdshot, he is already implying that it is not going to be the birdshot patient's savior. It must be used correctly, as the first person that ever put some steroid in a human eye in New York City at Cornell, Dan Gordon, learned early: come in boldly, treat it aggressively, and then slowly back away. One wants to see a quick response. I call it the fireman. It's like calling the fire department to put out the fire instead of putting the garden hose on it. One should see objective evidence of improvement quickly. That is to say, resolution of late staining of vessels and fluorescein angiography. Notice also this point that Carlos makes early on in his talk. And this just can't be emphasized enough. Do not, he says, rely upon this chronically. Do not rely upon steroids for a long time. Do begin the early introduction of steroid-sparing IMT. What does that stand for? Anybody? The patients all know because they hear it all the time. Immunomodulatory therapy, which is a mouthful, so everybody says IMT. That's the best option, Dr. Pavessio says, for long-term control of inflammation, and of course the corollary is long-term preservation of vision. He goes on to say that in advanced cases, when damage to the outer retina has already developed, there will be limited or even no response to aggressive corticosteroid therapy. So sadly, we do inherit cases late in the game when it's too late to really do much good, even with the fire department. Functional tests should show improvement in the findings if one is having an effect therapeutically. That is to say, shortening of the 30 Hertz implicit time on the ERG, and sometimes even improvement in the visual field. He shows a case, actually he shows several cases. The first is a 57-year-old female who presented with poor vision, both eyes, worse in the left eye than the right. The anterior chamber was completely without inflammation, but there were cells in the vitreous cavity bilaterally. And here's the appearance, and this has all now become familiar to each of you here with the rice grain spots in the retina. Notice also that on fluorescein angiography, the patient does have late staining of the optic nerve head and of some of the veins. With corticosteroid therapy, there was resolution of those findings. Spectacular. I mean, this is wonderful. It's very, very encouraging that the patient had such a good response to that. Here's the mistake. For the retina doctor to be so excited about this nice response that he or she simply continues to treat with corticosteroid monotherapy. And that's what was done here. The patient was put on monotherapy and gets worse, dose is boosted, gets better. The electricity behaved in the same way, better, worse with tapering, better with reinstitution of steroid. Notice that the dose that's being employed to get them better is ramped up. It's a very high dose, and by the by, the patients start to develop the complications of systemic corticosteroid therapy. How long do you suppose it takes for bone loss to begin in somebody on systemic corticosteroid? It begins at 3 months of therapy. 3 months of therapy. Most people don't know that, but that's what the bone biologists teach us. And so you really don't want to be on systemic corticosteroids more than 3 months. Carlos shows this graph that shows what happens with function in the retina with birdshot and a recovery with corticosteroid therapy, and then with kind of a trickling along by the by as steroid therapy is continued. He shows another instance of that here. I can't see it very well here. I'm sure you can see it better on your handout than I can from up here. Case 2 was a 60-year-old male presented with a 1-year history. Think about that. We see this all the time. A 1-year history of difficulty visually, and especially so-called nyctalopia, or difficulty in transitioning from a lighted environment to a more dark environment, walking into a movie theater, for example. But his vision wasn't so bad. He's 20/30 in the right, 20/30 in each eye. I mean, that's not too shabby. You've heard it once already, now you're hearing it a second time. Central visual acuity on the eye test in the doctor's office is an extremely poor monitor for following patients with birdshot. There's a whole lot more to the story of visual function than visual acuity. Here was the way this patient looked with the classic birdshot lesions, angiographic staining, and started on oral prednisone. Forgive me, I will do you a disservice by going through this because of the imperfections in being able to see it from up here, but follow it on your own and you'll see the fluctuation, improvement, and relapse with prednisone taper. Case 3 was 59 years old. For 2 months, complained of floaters and delayed adaptation to dark environment, sensitivity to bright lights. Here are the spots. Both eyes are involved. There are cells in the vitreous, and he's put on oral prednisone. This patient continued to decline in spite of oral prednisone therapy. And I come to Dr. Pavessio's summary slide or conclusion slide. Even though long-term control may be achieved with low doses of systemic steroid, this is likely to be more an exception. That is to say, few patients fit that description. And steroids should be used more to manage acute exacerbations. Call the fireman. Early introduction of steroid-sparing immunomodulatory therapy seems to offer the best option for long-term control. Close monitoring is essential for adjustments in therapy.